conversation, friend, and years of working together in what I will be presenting, Tobey Clark. What I will speak today about is more than 50 years from 1970 to 2010 and beyond of what happened in the health technology field in Latin America and the Caribbean. As a background, everything we could say in the new era started during the 70s, last century. Programs were developed with international organization support, but there was some initiatives at the country level, and there was inter-country and group of countries collaboration, like the Andean Group and the Central American Initiative, all working in the field of engineering and maintenance. During the 80s, there was a financial crisis. However, during this time, there was a fast development in medical technology, and all these new technologies were critically incorporated in the health sector in the countries. 90s were marked by a strategic alliance with the American College of Clinical Engineering and PAHO WHO, leading a process in collaboration with other partners. There was also an increased attention paid to universities and professional societies and the private sector. And this is because until this time, the academia was not involved in the field of provide the technology management programs. The new millennium was marked by the academic program, professional societies, certification programs, medical device regulation, health technology management, and expansion globally of all these programs. One of the key elements that put up front biomedical and clinical engineering was the Y2K, the year 2000 informatic problem. That was an opportunity faced and taken by the clinical engineers and technology management. From 2010 and beyond, there has been a global collaboration. Most of this program was expanded globally. Health technology assessment start playing a role in this area, and countries are working in having public policies dealing with healthcare technology. Now, in Latin America and the Caribbean, there was some that I call main drivers in this area. First and foremost, in most of the countries, the healthcare system are and still are segmented and fragmented. It means public sector, private sector, social security, and military health sector. None of those were collaborating or exchanging information and experiences until the probably beginning of the new millennium. For that reason, maintenance programs was mostly centered in government hospitals, and every other sector were running their own shows. Also, bilateral and country group alliance were established, as I mentioned before, in order to share experience, but mostly limited to the government institution. Also, there was international financial and technical support, like the World Bank, the Inter-American Development Bank, the PONDE from United Nations, and countries' cooperation to other countries. Also, during this period has been a strong technology change, new medical technology developments, and all these instruments and devices were incorporated in a critical form to the countries. Also, there was investment in healthcare infrastructure, more to buy goods rather than planning the life cycle cost of those technologies, and mainly the resources to operate and maintenance this. And something that has been always around is the financial crisis at country level, and the few resources allocated to guarantee the operation of this institution. But also, in addition, there has been, and I could say, worldwide challenges in developing countries. And the probably more important, in not a specific order, is the lack of national policy for science and technology in health. The countries almost are technology dependent countries, so they don't have inside the capabilities to produce, deal, and maintain these technologies. There are few medical devices regulatory programs that in a way could limit what is coming into the countries. Also, there is a limited use of evidence-based information for the decision-making and technology that could be incorporated in the country. There are few and very weak health technology management programs. However, there is a continued acquisition of technologies. And the programs dealing with planning the infrastructure to accommodate these technologies are very deficient. And still today, countries don't have inventories and control systems for the medical technology. Even today, we could easily measure that at least 50% of the medical equipment are out of service or not in use for very different reasons. We could have a conference just to deal with this specific area. Always has been a very low budget allocated to the engineering and maintenance programs, and there is a deficient maintenance system. Also had been deficient after sales support of medical technology. Buildings and facilities are obsolete and highly deteriorated. And there is normally a lack of planning for this physical infrastructure that need to accommodate the new technology. Human resources development to deal with all these issues has been very, very limited, and there is a shortage of professional and technical staff. One of the reasons few universities and technical schools has programs to deal with biomedical, clinical, or health technology management. Also, national engineering societies not include a clinical or biomedical engineering chapters, or there are not societies in this area. Other additional challenges in Latin America and the Caribbean are an obsolete communication infrastructure, although lately has changed a little with the communication through cellular networks. But there is still a slow internet penetration inside the countries. And also with the health technology programs are also low expansion inside the countries. Where you leave the capitals of the countries, I mean, you could not have any kind of technical support. However, still past technologies continue, and something that still is valid today, several countries depend for the operation of the health services in the technology donation. A very important point is an inside the country resistance to change the status quo in the healthcare sector and in the healthcare facility. And another one is the difficulty of the transition from project with international support, mainly financial, to be incorporated in countries as programs, adding the necessary resources. In 1981 until 2013, the American College of Clinical Engineering, the Pan American Health Organization, and the World Health Organization developed an initiative focused to develop human resources and strengthen health technology management at country level and worldwide. This strategy is called the Advanced Clinical Engineering Workshop. During this period of time, more than 50 advanced clinical engineering workshops were held worldwide. And I take a moment to recognize the leadership of our colleagues like Tom John, Toby Clark, Jadine David, and probably I should stop. Vincent One, I should stop here because I could not mention this large group of more than 100 professionals of the college that had been working as a faculty member. In this and the world, there was tremendous group of partners like the Health Technology Foundation, the Health Information and Management Society, the Integrating the Healthcare Enterprise, the International Federation for Medical and Biological Engineering, the ECRI Institute, the Medical Device Bureau of Health Canada, the FDA, the Center for Devices and Radiological Health, the Association for the Advance of Medical Instrumentation, the American Society for Healthcare Engineering, the National Center for Excellence on Technology in Mexico, the Institute of Electrical and Electronic Engineer, the Orbis airplane, the Pan American Health Exchange, and so many others that probably I'm not mentioned. Through this initiative, we have very important outcomes that has been a different level of development in countries, but part of those are always present in each country. The first one dealing with governance and strategy for the programs. Now, several countries have national policies in healthcare technology. There are groups at the country level for health technology assessment agencies. As I mentioned before, the clinical and biomedical engineer and technology management took a leadership during the Y2K situation, and they put us in a very unique situation that helped us to develop forward the program. Also, the organization of medical devices regulatory programs through the implementation of the PAHO resolution dealing with medical devices. A very important component because there was kind of a filter and commitment of the countries of what type of technology they should incorporate and under which condition. There was the organization of National Health Technology Center, like Cenetech and Cengetz in Peru. And then came a very important health technology initiative in WHO and an American Health Organization agenda, and I will mention this a little later. Also, there was WHO and PAHO collaborating centers in health technology that are helping to support the country's initiative. Also, there was a national, international healthcare enterprise in Latin America countries to facilitate clinical engineering, information technology, and electronic health record be implemented at country level. And there was academic and engineering societies taking the leadership to address health technology issues. Also, in the health technology management and clinical engineering, health technology was incorporated in national health plans, and health technology management and health technology assessment are institutional priority in several countries. Hospital directors and administrators are nowadays very involved in health technology management, and clinical engineering department in hospitals are common issue nowadays, and clinical engineering has been widely promoted. One of the important aspects has been paid to sustainability, and that has been through established national strategic alliances, public, private, and academic partnership, the coordination with scientific and professional society, the work with international agencies, organizations, and NGOs, institutional capacity building in infrastructure and technology at the country level, participation in global initiatives dealing with different aspects of health technology. We could say as a conclusion that some countries are taking full advantage of this initiative, like other ones are just trying to work and find the way to move forward, but always having the support of the more advanced or developed countries in this area. What is important for me today as a reflection is when personally started this at the beginning of the 70s, there was a very significant change on technology, moving from the electromechanical and mechanical system to electronic and microprocessor-based system that changed completely the scenario and the profile of the people working in this area. Now, almost more than 50 years before, we are facing similar change with the incorporation of information technology and communication to the medical technology that are impacting the way professionals are working and interacted in this area with other actors in this process. So it's something that could be handled just going through the different steps were taken during the past decades in order to firmly advance these programs. And for any specifics, in the Caribbean area, I will invite Tobey Clark to address what is happening. Tobey has been taking this lead since I left Bajo back in 2010 when I retired. Thank you.
Thank you, Antonio. You definitely were a mentor for me. I didn't get involved in the ACEWs into the current millennium, 2000. Ecuador was my first stop, and the groundwork that you and Tom and Yadin have laid for the ACEWs was so useful in terms of the 18 ACEWs that I had been involved in, very fortunately. So again, in starting working with the Latin America and the Caribbean, the initial ACEWs started off covering very basic topics related to primarily planning and HTM, and then later moved as we approached 2005, 2010 into the more specific areas that were very important. And I'm talking primarily about digital health. We had special sessions on things like PACS systems and electronic health record, some of the other advanced systems that are out there. So, again, I think I just want to point out Antonio's home country of Colombia. I was involved in 4 workshops there, and over the years we've had students from Colombia and other countries, and it's really has reached the point of advanced clinical engineering in Colombia. At a level, equal to many countries in the world, certainly. So I think those workshops were very useful, and the follow-up with, student internships and, additional coursework by the engineers there has really paid off. Just to go through a couple of things that were focus areas for us in the workshops. Safety. There was typically a survey of the health system that may take place, say, the day before the workshops, and previously in other events, that we really wanted to focus on the safety, and not just electrical safety, but all types of safety, bloodborne pathogens, electromechanical safety, et cetera. And I think that was very beneficial to help out the countries who didn't realize things like you can't put an air conditioner in the operating room window, things of that nature. So the infrastructure, as Antonio had pointed out, that's a key part of the technology. And I think that, the workshops really tried to help focus on that area. The other area that I think is still a weakness in the Latin America, and particularly the Caribbean, is just decommissioning of equipment. There's a lot of very, very old equipment that either never gets thrown away, disposed of properly, gets put in a warehouse. There's sometimes some federal rules that prevent, say, disassembling equipment, putting it into recycled channels. So that's an area that I think has been helped by a guideline from WHO on decommissioning, because it is an important area to really advance the technology. You have to, first of all, get rid of the current that is not working. That's an important area. The other area that Antonio had talked about that is still kind of a weakness is donations. Donations really should be handled the same way that newly purchased equipment is, in terms of the what's needed for sustainability of those donations. And that is, of course, also based primarily on need. Do they really need this technology that they're being donated? Because a lot of factors that are part of that, whether it's the infrastructure, or if it's the training of the physicians or the maintenance staff. Is it consumables that are needed to be able to support that technology? So I think that's an area that still needs a lot of work. Just to now just kind of move to the Caribbean, as Antonio mentioned, I've been pretty much working in the Caribbean over the last 4 or 5 years as a PAHO consultant. And it's really, again, there are strong points, strong countries that have somewhat developed clinical engineering. I wouldn't say they're active in terms of societies, because it's basically a bunch of island nations. They can't get together very easily. In fact, when we had a workshop, ACAW workshop for the Caribbean in 2019, all the participants came to Washington, D.C., rather than going to an individual island, because it was cheaper. So that prevents the formation of societies. Is kind of more difficult than perhaps in South America or Central America. So again, there's stronger countries and weaker countries. Finding that in terms of technical expertise, a place like Cuba is really, they offer very beneficial services to the other countries, not only in the Caribbean, but in Latin America, to provide technical expertise. And then the larger islands do have a more developed clinical engineering program. But one thing about all the interaction that I've had with the Caribbean or Latin America, anything to do with PAHO or WHO, is that the participants want to learn. They want to improve their understanding of clinical engineering and application of clinical engineering. They're very have a lot of energy. It's all of the societies, really are investing a lot to learn more, to be more, to help the bottom line, the patient, to be safe and to be treated effectively. So I think I'm going to stop there and thank you all for this invitation.